unless the cracks are in a buccolingual direction, okay? So as you can see here, you can see in this maxillary molar, you can see the crack here. And the reason why you're seeing this crack is because it's in a buccolingual direction. But generally, as I said before, cracks go in a mesiodistal direction. Because the x-rays are taken in a buccolingual plane, they will not be able to detect cracks in the mesiodistal direction. So that's why when patients come to you, they say, is it showing on the x-ray? Is there a crack in the tooth I heard? Is it showing on the x-ray? And the answer is no, unfortunately, it doesn't show on the x-ray for the most part. Make sure you tell patients that. Bone pattern and loss is what sometimes will suggest at a cracked tooth. Like for instance, as you can see here, there is a little bit of a bone loss on the distal of this mandibular molar. These are the type of things where you would expect there's probably a crack in this tooth. Very shallow restoration, and there is a little bit of a bone loss on the distal, and this is where the bone is reacting to the crack line on the distal of the root. That's what we see, pattern of bone loss. Typically, you see a J-shaped lesion as well in some cases, not all of the time, and that's also indicative of a crack. In a root canal treated tooth, it will look very typical like this, where it's a seemingly well done root canal treatment and having this radiolucency around. And also here, you see the type of radiolucency. These are typical presentations of a cracked tooth in the radiograph. Not so much you would see the crack itself, but you would see how the bone is presenting to it. Sometimes you have to remove the restoration to be able to see the crack. For instance, here there is a temporary restoration. Once you remove the temporary restoration, you can actually see the crack on the floor. Unfortunately, you won't be able to visualize this crack. Otherwise, because this entire tooth has a mesial-occlusal distal restoration, so you won't be able to see it unless you remove the restoration. Magnification is very, very, very important. I mean, I cannot overemphasize the fact. At a minimum, you should have some loops with from LED light, so you can have bright light, and the loops will be able to show you at least maybe a 2.5 a minimum, maybe a 3 something or a 4 would be better, you know, in order to see these cracks. And you should have a very good light associated with the loops. But obviously, the gold standard really is a microscope. Having a microscope makes things much, much easier for you to be able to diagnose cracks. In terms of magnification, what it can do, I just want to give you one clinical example. Here is a maxillary molar that had a previous root canal treatment. There's a sinus tract. So I traced the sinus tract and I said, okay, well, could be a missed MB2. Let me go inside and see what's the problem. So I opened the tooth and I saw the MB2 here. As you can see, these are the other canals that are filled. There is a missed second mesiobuccal canal. I said, wow, this must be the reason why the tooth failed. So I cleaned out the canals. And when I was cleaning out these canals, and I'm thinking, gosh, there is something here. Vaguely, I see something here. So I increased the magnification. And guess what I see? There is a huge crack running from the mesiobuccal tooth canal all the way to the palatal. And that's precisely the reason why this case failed. Not so much because there was a missed canal, but that tooth actually cracked. If you did not have a microscope and you're not using magnification, these are very hard to find. It's almost impossible to find because this magnification is 16 times. 16 times I was able to see this. So that's the importance of magnification. Staining is also useful in a case like this where I'm suspecting a crack on the mesial root. Where the pocket is, I typically place a dye, whether it is a methylene blue dye or you can take one of these ultra dense dyes, and then you can apply the dye at the CEJ, and then take a very sharp instrument and peel away the gingiva slightly, and then you can actually visualize the crack under a microscope. So this saves you a lot of time, wherein you don't have to go into the tooth and try to detect what's the problem. All right, transillumination is another aspect that you would want to look at. When you pass light across a tooth, if there is a crack, then light will not pass because it won't transmit through a gap. So light goes through the tooth, hits the crack and stops. And then the rest of the tooth would look normal and you can see clearly where the crack line is when you transilluminate. So it's always handy to have a small external light source that you can shine on at the tooth with no regular light, dental chair light, and you can actually see where the cracks are. It's called transillumination. And sometimes you can have to surgically explore and check the crack. Here there's a flap was raised and you can actually see the crack running right across, as you can see in that mirror view, on the surface of the root apically, and then going down the entire length of the tooth. So these are only seen after surgical exploration. So what about CBCT? Does it have any merit? There's a paper that came out some years ago in the JOE. So basically what they're saying in that paper was, in CBCT, if you take a scan, you would see loss of bone in the midroot area with intact bone coronal and apical to the defect. Absence of the entire buccal plate of bone in axial, coronal, and or 3D reconstructed view. So no buccal plate at all. Radiolucency around a root where a post terminates. Space between the buccal or lingual plate of bone of root surface. So in other words, there's some space between the alveolar, the buccal plate and the root surface itself. And rarely you can even visualize the crack on the CBBT view. So these are some of the things that you can see. And I'll show you some cases where this can work or it may not work. So let's look at a case here. What we're looking at is a 75-year-old male with occasional pain to chewing in number 13, which is this tooth here, the second premolar. Root canal and crown were done many, many years ago in both these teeth. When I tested, 13 is slightly tender to percussion, number 13, but the probings, there are no pockets at all. So I'm thinking, okay, maybe there is a problem. So with a missed canal or something. So I took a scan. As you can see here, the scan, I'm going to speed it up a little bit. This is the axial view of the tooth, and you can see there is no buccal bone here. So you can see clearly the buccal plate is missing. Look on the buccal surface there. There you go. There's a separation between the buccal plate and the root surface, which is right here. So we go down. And then, of course, apically, there is a small periapical area, but nothing major. And then if you look at the coronal view of the tooth, as you can see here, this is the separation between the buccal plate and the root surface. There is a gap. And that's what they're talking about in that paper. As you can see here, it seems like a well-filled root canal, and you can see the space between the buccal plate and the tooth. And once again, you can see it right there, right where my arrow is pointing. And that's what they're talking about. Okay. So after looking at the CBCT, I felt it could be a cracked tooth. So what I had done is I raised a flap just to be sure. And sure enough, you can see there is a crack in the root. So why is there no pocket in this tooth? There's no pocket because the crack did not extend all the way coronally. It started apically and it started coming down coronally, but never made its way all the way to the CEJ. So that's why I could not get any probing here. And that's very typical of some of these cases as well. So you have to be mindful of that. Now I'll give you another example of being the devil's advocate. Here is a tooth that is failing, a molar. And so it looked like to me a mesial root probably is cracked, but I just wanted to make sure that there are no missed canals. So here is the tooth, and you can see both mesial canals are filled, and you can see this big radiolucency on the buccal aspect. Actually on the lingual, sorry, this is on the lingual. And you can see the entire buccal bone is gone. So this to me, I look at this and go like, this tooth is definitely cracked, right? So that was what I was thinking. And here is the sagittal view of it. Once again, you can see this large radiolucency in a pretty decent root canal treatment. And you can see how that radiolucency comes all the way to the top. So once again here, big space between the lingual bone and the root surface itself. And if you look at this, the tooth itself, hardly any bone around it. So I looked at this scan and I thought to myself, this tooth is definitely cracked. So I told the patient, poor prognosis, let's remove it. And I removed the tooth. And when I looked at the mesial root under high magnification, I did not see any cracks. So this is not a cracked tooth. This has some other issues causing the failure, but definitely not cracked tooth. So once again, the CBCT findings, you have to be careful of what you're seeing and what you're interpreting. Here is another example of it. A tooth that had a root canal treatment done, a mandibular premolar, has a large screw post in it root canal treatment done. Now there is this kind of J-shaped lesion around it. And there is a sinus tract heading straight to where the post is ending. So here is the scenario. I mean, I'm looking at this and I'm thinking, maybe the root cracked at the base of the post. But I wanted to make sure there are no missed canals. When I took the CT scan, guess what? There is a missed canal on the lingual of this mandibular premolar, because as you can see, the filling, root filling, is actually more buccal and not centered in the root. So this view clearly tells you that there is another canal on the lingual, and that is the sinus tract, and that's the reason why this tooth failed, not so much because there is a crack. So obviously with that knowledge now, of course, I will have to retreat it, and that's what I have done. Found the other canal and restored it. And then of course at 5 years, this tooth looked perfectly fine, doing very well, no issues. So once again, there could be an issue if we blindly believe that if there is a sinus tract heading to the base of the post, that the tooth is cracked. We have to be careful, because in some instances it may not be the case. Okay. All right. So what else do you have here? Okay, so there's another tooth here I would like you to see. Once again, similarly, there is this premolar, maxillary first premolar with the previous root canal treatment, a large radiolucency, big post. There is a sinus tract, and there is a pocket distal to number 12 here. Somewhere here, there is a pocket. So I'm thinking this tooth is definitely cracked, you know, but I wanted to make sure. So I took a CT scan, and here I see what appeared to be a line. So many times people would believe that this is actually a crack that they're seeing, but it is not. It is just an artifact. It is not a crack. Please don't think that CBCT can show these sort of things, especially when there are root canal obturating materials around causing these artifacts to open up. Okay, so it's a reconstruction artifact. It makes you believe it is a crack. But remember, the pocket is on the distal. So this is where the bone loss is. So if at all there is a crack, you may be seeing it in this direction, not necessarily there where there is good bone. So I said, okay, well, let me give it a shot. Let me see what happens, because it's not very conclusive if this is a cracked tooth, but I still told the patient, let me try. So I took out the post, I cleaned out, didn't see any cracks inside the root. I completed the treatment. And then of course, at 8 months, everything healed up nicely. And then of course, took a CT scan, and all the bone came back on the distal. As you can see, where there was bone loss before, this is 20 months, that is like a year and a half, and everything seems to be healing nicely. So here is the J-shaped lesion in the CT, and then this is 8 months, the entire thing is healed, and this is 20 months, everything has healed nicely, no issues, patient is happy. So point of this case, once again, is be mindful of what you're going to see at a CT scan. As you can see here now, full bone reconstruction all the way around here, good repair. So CTs are not very definitive, my take on this, but you need to know what you're looking at when you order a CT scan for this. When in doubt, refer it out. Root canal treatments, retreatment being carried out in multiple appointments by this dentist in number 30. Patient continued to have persistent pain. So the dentist kept working on this tooth and saying, oh, you know, let me put some more calcium hydroxide, and kept adding the calcium hydroxide for months, until finally he made the referral. And when the patient came to see me, when I tested the tooth, obviously the problem, as you can, I don't know if you can read it, number 30, the first molar is not the major issue, but number 31 is the one that has severe lingering core sensation, and that's what the patient has been feeling, not so much what's happening in tooth number 30. So when I checked the tooth number 31, I don't know if you can see it, but there is a crack on the distal marginal ridge going all the way down here. So the problem tooth is actually this, not necessarily this. And the dentist spent months trying to fix this tooth, not understanding that the problem was in 31. So sometimes it's good to refer these patients to specialists when you cannot really figure out what is the issue, rather than wasting your time and the patient's time and all the discomfort you're causing to the patient. Okay. So this particular patient chose to take out the tooth because he felt the prognosis. We thought the prognosis is not so great for this tooth, and he opted to take it out. All right, so what are the treatment options we have? In the first type of crack where there is just only no pulpal involvement and just a part of the cusp is cracked, then cuspal coverage is a good way to treat it. If there are cracks that have pulpal involvement, then definitely you need to do root canal treatment immediately followed by a crown. That's as important as the root canal treatment itself. Cracks with an attachment loss, the third type, then you have to start discussing the depth of the crack, the depth of the pocket, what's the patient expectations are. Would the patient likely to feel guilty if this tooth were to fail down the line, whenever that is? So then you have to discuss whether it is extraction or root canal treatment followed by a crown. So there is a lot of discussion in these type of cases with patients before you treat them. Complete separation of fractured segments, clearly extraction. There's nothing else you can do. And if there are apicocoronal cracks, more than likely extraction, but you can get an innovative and then do some treatments like root amputation and hemisection, and I'll show some clinical examples for all these. All right, so let's look at our first case. When there is no pulpal involvement, obviously the idea here is a part of the tooth cracked but not involving the pulp. So you remove the part that is cracked, and then you place an onlay or a crown. The idea here is to, have this bind the fracture segments barrel stave effect, as they call it. You have a barrel with all these cracks lines, and you put these metal rings around them to hold them together. So that's the basic concept when you're doing these onlays and crowns. And they are essentially holding the fragments together and not necessarily causing any symptoms like fluid movement and sensitivity in the tooth. Classic example of in my office, here is a tooth number 30, first molar. Patient was referred to me saying that, okay, please provide evaluation only and also root canal therapy if I think it's necessary. Patient is having pain. So when I tested the tooth, what are my findings? Essentially, everything is pretty normal except bite. When the patient bites down, there is sensitivity on release. Cold is normal, medium. So my diagnosis is normal pulp. And then I said, okay, let me see what's going on with this tooth, more than likely cracked. So I gave him an appointment to come back. And by the time he came back, a part of the cusp already broke because it took 2 or 3 weeks for him to get the appointment. And in the interim, he actually fractured off one of the cusps. So this is typically, and then after that, the symptoms usually get better. They hardly have any issues because the cracked cusp has actually come off. So when I removed the amalgam filling, I actually saw the crack extending on the base of the other lingual cusp, the distal lingual cusp here. So I said, okay, let me remove that cusp. So I removed the cusp. And then I placed a resin onlay. It's a direct onlay. I just did it under the microscope in the chair. But you can also take an impression and prep the tooth and then prepare for an onlay or a crown in a scenario like this. So here is the tooth, and I normally tell these patients, look, there is a very high chance that this treatment alone is what you need, and you may not need anything else. But in some small percentage of cases, maybe 1 in 5, your symptoms will continue to persist where you still may have continued biting pain and cold sensitivity. So if that is the case, come back in and we may have to do a root canal treatment in these cases. This particular patient had no problems up to 2 years. And after that, he had some issues and then we had to do a root canal treatment at that time. So typically these teeth present like this. As you can see, this is not a cuspal crack. This is the other type of crack. So this is the dentin involving the pulp. Crack going obliquely into the dentin involving the pulp. So you can see the crack going straight down here into the distal root. So you have a discussion with these patients and say, look, but there's no attachment loss in this particular case. So we decided to do root canal treatment. Root canal treatment was done in 2009. Patient came back in 2010. Everything looks fine, has a crown on the tooth. So tested within normal limits. And this is 2014, 5 years later, the tooth is still in patient's mouth and perfectly fine. And then you have pulpal involvement. Again, one more case like this. You can see here, the first molar has cracked. I don't know if you guys can see the crack. So patient has symptoms, cannot chew on the tooth, very sensitive to cold. So I removed the restoration. I could see the crack heading from on the lingual and the distal. So here's a root canal treatment done. You can see the crack line extending into the pulpal floor. And here, so I explained to the patient, this was sometime in 2007, I did this. Patient interested in saving the tooth, a guarded prognosis. So patient wanted to keep the tooth, so I did the root canal treatment and placed the restoration immediately. And I prepped this tooth so that the patient can immediately go to her dentist and get a temporary crown. And this is 3 years later, everything is perfectly fine. And this is 7 years later, everything is still perfectly fine. I haven't seen this patient recently, but I'm positive if there is a problem, she would come to me for a follow-up. So this is 7 years and no problems. And here is another condition, this time with attachment loss. So this particular case, all the symptoms are the same: biting pain, temperature sensitivity. And then when I probe the tooth, there is a 5 or a 6 millimeter pocket on the distal of this tooth. So in a scenario like this, you have to discuss with the patient what depth of crack, how deep it is, how deep. So my discussion with this patient is, look, it at least goes 4 or 5 millimeters below the gum line. And I tell them the chances of this tooth surviving in your mouth over a period of time are not as high as another tooth that would require root canal treatment, but no crack in it. So the prognosis is not as great as that type. So you need to think about whether you want to keep this tooth or extract it and place an implant. And there will be a discussion with the patient, and the patients, some of them are fine with it, they want to try it, some of them are not fine with it. In those cases, you extract the tooth. And I always tell the patients, look, if you feel in 2 or 3 years you lose this tooth, you look back and say, gosh, why did I make that decision some years ago? I should have just taken this tooth out. And you feel very guilty having taken that decision. If you are like that, where then do not save the tooth, just get the tooth out. But if you're a kind of person who would say, oh, well, I made the decision, it gave me 3 full years and I was able to function with this tooth, I'm happy with that. And now that this is gone, now I'll think about what can be done to replace this tooth. Then you should save the tooth because you have the right frame of mind. So let the patient make the decision rather than you do it. So this is back in 2009. So the patient wanted to keep the tooth, so I did the root canal treatment. And this is at 5 years. Patient is still doing absolutely great. No problems, has a crown on this tooth, everything seems fine. Not much breakdown here on the distal, looks pretty good. And this is another 5 years, 10 years now. So this is at 10 years, patient still has the tooth, everything looks perfectly fine. So for this patient, it really worked out very well because after 10 years, they still have the tooth. This is another tooth that I treated in 2010. Typically, as you can see radiographically, these present with shallow restorations. Hardly any issue if you look at a radiograph. But then if you look clinically under a microscope, you see a crack. And then this is a crack heading towards the pulp. So I did a root canal treatment on this tooth. And this is back in 2011 at 1 year. He has a crown on it. Everything looks fine. This is 5-year follow-up. Tooth looks fine. Crown looks fine. At 10-year follow-up, this is last year. Everything looks perfect. Yeah, so another case where the patient chose well and it worked beautifully. Here is another example. Here is a mandibular first molar that had a treatment already, but patient is having symptoms. So when I looked at the tooth, I see a crack on the distal. So I'm thinking, is that the reason why this tooth is sensitive? But then I also located a second distal canal in this tooth. So there are 2 distal canals. So maybe that was the reason why it was sensitive. So I retreated it and I placed the amalgam and then I closed up the tooth. And this is back in 2008. And so 2008, 1-year follow-up, she looks fine. 11, 4-year follow-up, she looks fine. And 2014 at 6.5-year recall, the tooth is still looking very good. And this is 2020, 12 years later, the tooth is still in the patient's mouth and doing very well. So clearly it was a good decision to retreat this tooth and address the problem, and patient still has this tooth after 12 years. Same patient on the other side, The first molar again cracked, as you can see here. There is a crack heading straight to the distal root, and I did the treatment. Here is the two distal canals. This because I know from the other side there are two. I was looking for it, and I found the two distal canals. So this is at 6.5 year recall. The other side, the first molar is looking good, and this is 12-year follow-up, and other side looking good. So this particular patient has made a decision to save her cracked teeth on both sides, and after 12 years, both sides are functioning well. It's a good decision again. Another case here, the second molar has cracked on the distal. As you can see, there is a little bit of bone loss. You see the pattern here, some radiolucency apically. Patient opted to keep the tooth, so did the root canal treatment in 2005, and this is at the end of the treatment. And look at the first molar, which already had a root canal treatment done elsewhere before I got involved. That tooth looks okay at this time. So patient came in after 5 years, or 2009. The tooth that I treated looks good, the one that is cracked, but then the one in which she did the root canal previously is failing here on the mesial. So I retreated that in 2009, and then this, after a year, it has healed nicely, the other one. And this is 2015. This is 10 years after my treatment. The tooth is still looking good, and the patient still has this tooth in her mouth. So this is now 15 years. The second molar has survived, and also the first molar. So good longevity again. Another classic case here, very poor prognosis when I look at it now, because it has sort of C-shaped canals, missing tooth here, a lot more occlusal load. I would think, is this going to make it? So I told the patient, it's necrotic pulp. So very classic cracked tooth with pulpal infection. But patient is very keen on keeping the tooth. I said, okay. So I did the root canal treatment in that tooth. And this is at a year. He's looking good. I told him get an implant in this area, but for some reason, maybe because the clinical space here is very limited, he couldn't get an implant. So he just kept it like that. And this is after 12 years. The tooth is still in the patient's mouth, and I had to do a root canal in the third molar. But interestingly, the second molar survived almost after 11 years, 12 years, it's still there, even with the missing tooth next to it. So patient got lucky. Another tooth like this again, as you can see the pattern, shallow restorations, sometimes periapical radiolucencies or sometimes symptoms, and you take the restoration out, you see a crack typically heading into the chamber. Here is the root canal treatment done for this particular tooth, and this is at 18 months. As you can see, the entire lesion has healed beautifully. And this is, what is this, 11 years later, a couple of years ago, he still has the tooth looking pretty good. So maybe a little bit of caries coming along. So I asked him to go check his dentist and remove the crown and check if there is any recurrent caries. A maxillary premolar that I treated here, 2002. And if you look at this particular tooth here, when I removed the amalgam here, there is a crack. I don't know if you can see it, but here is the crack heading down into the pulp chamber. So same discussion with the patient. We decided to keep the tooth, patient and I. So we did the root canal treatment. So if I were to follow this up, this is in 2002. If I were to follow this up in 5 years, which is the tooth more than likely to fail? According to our knowledge, we believe it would be this cracked tooth. Let's look at what really happens. So when the patient came in 2010, which is 8 years after, the first molar at some point failed, and the patient had to get a root canal treatment in the first molar and a crown. So, okay, so it's the first molar that had problems, not so much the premolar in which there is a crack. So patient comes back in 2015. This is 13 years after the treatment. Guess what? The bridge retainer, the first premolar is gone, and the cracked tooth still present very much. So it's hard to say which teeth work, which teeth don't work. So it's always good to be humble about these cases and discuss all options with patients before you make decisions. Another tooth that I treated in 2003, here is a second molar here with a pocket, a good 5-6 millimeter distal pocket. Similar discussion with the patient. Patient opted to save the tooth because they felt, they wanted to get whatever they can from the tooth. So here is a crack on the surface. You can see clearly. And here it is on the pulpal roof. You can chase it. And as you keep chasing, the crack keeps going down, down until it ends up into the pulpal floor. I mean, not on the floor, but into the chamber. So do the root canal treatment, completed the root canal treatment, and 12 years later, in 2015, we did it in 2002, 12 years later, this tooth is perfectly fine. Yes, a little bit of a bone loss on the distal, which I expect from the crack. But look at the first molar. That's the one that is breaking down. So it's actually the first molar that needed treatment, and his second molar is perfectly fine. Once again, goes to show that you never know what works and what doesn't in some of these cases. I treated this second molar in 2001, and patient came back in 2008. Everything looks great. It's a cracked tooth, obviously, on the distal. No problems 7 years later. And here it is 16 years later. The tooth that is cracked still is looking good, but the first molar had an issue and patient had a root canal treatment done elsewhere, or not in my office. And now he has a problem with this tooth. And he came in asking me to check this tooth. And I realized the tooth that I did back in 2001, 16 years ago, worked beautifully, even though it was cracked. So these are some of the examples, but not all of them work. Some of them fail, and I want to show you as well. So this is a maxillary first molar that I retreated. As you can see from my notes, there is a fracture on the mesial marginal ridge, not extending below the floor of the chamber. So prognosis is fair, in my opinion, and I did the treatment. So patient comes back exactly 4 years later with a deep pocket on the mesiobuccal root, and the tooth is cracked. So basically, you have to extract the tooth. Now, another example of this, I retreated this tooth in 2008, a molar, and then this is completed treatment. Very little tooth structure, so not really a great candidate, but patient wanted to keep the tooth, so we did it. So when patient came back, follow-up, everything looked great, but then at a 5-year follow-up, the root, mesial root has cracked in half. So once again, lack of strength and weakness in the tooth and not much tooth structure. So these are the things that can happen, and you have to be mindful. In some small cases, you can do some heroics. Like for instance, root amputation is one of them that you can consider. This particular patient had a root canal treatment done in maxillary first molar. He has a deep pocket associated with the mesiobuccal root. So there's a crack that I could see running on the root surface. So we talked about it, and then patient said, is it possible to keep this tooth? I said, okay. One thing we can do is remove that particular root and leave the rest of the tooth if you're okay with it. Patient says, yeah, let's try it. I said, okay, let's try it. So I did a mesiobuccal root amputation and left the rest of the tooth. I retreated, I didn't retreat the root canal system, all of them, just the palatal to put a post. So I placed a post, I did a build-up, and then I removed the mesiobuccal root, which is cracked. So here it is after a few weeks. Everything looks pretty good. Then dentist went ahead and placed a crown. So a 2-year follow-up minus the mesiobuccal root. The tooth is doing very well, and the periodontium is looking very healthy, and patient is happy at this time. We don't know how long these things last, but so far so good. One last case I want to show with you before my time runs out. I have another 2 minutes. This is Jaden, who is a 12-year-old boy, young fellow, fell, hit his tooth, and then he cracked his central incisor. As you can see here, the tooth vertically split. You can see the split on the palatal side, right? And the dentist saw him immediately, removed the pulp. The palatal half of the tooth fractured 14 millimeters from the incisal edge. From here, 14 millimeters below is where that crack extends. So he sent the patient to me and said, figure out what to do. So when I saw the patient, I said, okay, let me do something. What I'm going to do is first, I know that if I remove the fragment on the palatal, it's going to cause a huge defect on the palatal. So I just completed a root canal treatment for him with poor isolation because I couldn't keep the bleeding out of the cracked part of the root. Then I fiber post in it. You can actually see the crack line here running along here. And then I placed a crown. His dentist placed a crown. This is back in 2011. He was fine until 2012. He was okay. He came in 2013 with a swelling on the palatal. So clearly now things are breaking down on the palatal side. So I took a CT scan, and you can actually see the crack on the lingual at about 14 millimeters from the incisal edge. You can see the bone loss in the axial on the palatal side, and then you can actually see the crack running along the surface here. So at this point, I had a discussion with Jade. I said, with his mom, obviously, you may have to take this tooth out, or if you're okay with it, I'll send you to an orthodontist who is going to extrude the tooth all the way out to the point where this crack gets exposed. And then we can do a crown lengthening to remove all the bone that came with the extrusion and then save the tooth. She said, well, let's try for it, because she wants her son to keep the tooth. So this is the tooth back then. And then so the patient went and did orthodontics and extruded the tooth. As you can see how the gingival margin, as you can see, it came down so much. It was originally somewhere here. So from here to here, the tooth extruded. Now, mind you, when you do orthodontic extrusion, slow extrusion, you also bring bone and the attachment with it. So the entire tooth with the attachment came down. And as it is coming down, the dentist would keep shaving the tooth back so that it's still an occlusion. So when finally it arrived at where you wanted it to be, where the crack is now completely out, 14 millimeters out from the existing original gingival margin, then the periodontist went and did a crown lengthening to remove all of that excess gingiva and the bone around the tooth. So if you look on the lingual now, you can see barely here the crack line. It is at the gingival margin. So I wanted this crack to be another millimeter or two super gingival. So I asked the periodontist to do another crown lengthening so he could take out a little bit more of the attachment on the lingual. Now, mind you, this tooth is 28 millimeters long to begin with. So it has a lot of root, and we were able to do this procedure. So after all the extrusion is done, the entire crack is actually outside. Patient kept changing the temporary crowns until they got the final decent result, and finally got, my wife did the crown for him at this point. And this is the attachment now on the buccal. So this is how we started out when the tooth was extruded. As you can see, these big gaps, but these are managed with the restorations on the lingual temporarily, obviously. And then of course you have all of this crack now fully exposed to the mouth. So there's no part of the root under the attachment that is cracked. So now there is a new restoration, a new crown. And this is how it was in 2010. This is 2015, and this is 2019. So after 10 years, Jaden is almost 22 years old now, and he still has his tooth. And if you look clinically, this is what we started. This is how he was, very nice crown. And this is in 2016, still looking pretty good. The attachment looks very nice. And this is 9 years later, still the attachment looks great and no problems. And I don't expect this tooth to fail anytime soon. And if it fails eventually because of maybe a fracture or something in this tooth where the tooth breaks off, then he can always get an implant, because we are bringing this guy from 12 years into a time where it all can be done with a decent replacement. So what are my observations with cracked teeth? Cracked teeth are unpredictable over long term, but not all cracked teeth are poor teeth to say, as I have shown you in multiple cases. A disproportionate amount of cracked teeth will be lost over long term when compared to non-cracked tooth with initial root canal treatment. Yes, I do agree that some of these will be lost in time, more than compared to other groups where there are no cracks. But the key aspects in making the decision in order of the preference are, what's the extent of the crack and the attachment loss? If the crack seems to disappear down into the root, associated with over a 6 millimeter pocket, if it is extraction in my book, unless patient wants to keep it at all costs. You need to gauge what the patient expectations are. Is the patient an optimist or a pessimist? Is their glass half full or half empty? Occlusal load. Why did the tooth crack? Are there any missing teeth? Is there parafunction? Are they structurally compromised, etc.? Tooth type and form. Fused root form in the mandibular second molars and maxillary premolars are poor candidates. Separate roots with good bone in between seems to be a better candidate. Now, if you look at all these factors and you put them on a sliding scale, one end of the sliding scale is a poor candidate, the other end of the sliding scale is a good candidate. Like, for example, lots of missing teeth, excessive occlusal load in a guy who is a lot of parafunction, fused roots, and lots of high expectations. This is the worst case scenario, and you don't want to be treating this tooth. On the other hand, everything like, all dentition is there, no parafunction, there's separate roots in the tooth, patient's expectations are low, they're not expecting anything major, then do the root canal treatment and crown, and perhaps, as you know, you never know how long these things last. The rest fall in between, basically. Ultimately, it will be a clinical decision you and your patient will have to make together. It's not a unilateral decision. And do not expect a randomized clinical trial. And even if there is one that comes out, it can never apply to your patient in share with any degree of certainty because everybody's factors are different. So what the summary is essentially, take a good history to diagnose it, understand the limitations of radiographs. You cannot see cracks on radiographs typically. Understand the limitations of CBCT as well, and the artifacts that you can see in CBCT, and do not confuse them for cracks. Early diagnosis is very important. You might say which one is cracked and which is not. It's kind of hard to tell, but if the symptoms are there, you need to be able to diagnose it pretty good. Communication is important. Speak to your patients. Get good history on these teeth. Find out patients' expectations, very important. Do the treatment immediately. Please do not put it off, because between the time they come to you and then they eventually end up getting the treatment, the tooth can just break or crack and then that's gone. Interim restorations, if you're doing this root canal treatments in these teeth in 2 visits, ensure that you put something like a self-cure glass ionomer in the access as an interim restoration, and even place an ortho band or something like that to hold, or a temporary stainless steel crown, something like that holds the fragments together like the barrel stave effect. Immediate cuspal coverage. I tell patients, if I do a root canal treatment, within a week or 2 weeks, you're going to get a crown on it. And if you're not promising me that, then I cannot promise this tooth will last. That's very, very important in the initial conversation. And specialist care is important in some cases. Not all of these cases can be handled by the general dentist. So it's be careful in your diagnosis. And if you think a specialist care is needed, please send. It's not about your ego or anything. Just send them to the specialist so they can manage it better. And then, of course, follow-up is very important. You need to ensure that these patients are coming back so you can keep checking them if there is any further attachment loss, so that you could plan the next step. And also understand from a generalist point of view, if you are the general dentist for the patient, what caused this crack to begin with, and try to educate these patients that, look, some of these things that you eat or the way you function, the parafunction, all of these things have to change. So that's also very important. So coming back to the first slide that I showed with cracks on the pitch. So cracks, nobody wants to see cracks. I mean, you go to GABA, especially, you don't want to see cracks on a pitch, and especially if you're batting on the 5th day, like the Indians did. But if you know what you're doing, and if you have the resolve and the knowledge and the skill, like these guys here on the right, you can have a winning combination. You can successfully treat these cases and be successful, and patients would enjoy it. Like the Indian team had performed at the GABA on the 5th day. What a memorable test, what a memorable victory. Thoroughly enjoyed it. I happened to see it live until 3:30 in the morning, and it was one of the best days in my life watching cricket. So if I have any questions, guys, I mean, obviously you can put out, the other panelists are also going to respond, but hopefully most of your questions are answered in this presentation. If you have any further questions, feel free to ask, and I thank you for your attention. I hope you followed the presentation and you enjoyed it and learned something from it. Thank you very much.
Thank you. Thank you very much, sir. That was an amazing insight into the most perplexed subject, which you have made it very simple for all of us who are sitting here, sir. The excellent documentation of the case records would be helpful to all the students who have logged in. So you have stressed the importance of documentation. So it's not just the theory which matters. The documentation of our work is very important. And you have just, we can say, cracked the hard shell of a walnut and given us the essence, sir, with this presentation of yours. We have everybody of us would have enjoyed definitely the power pack presentation, every minute of it thoroughly. It was just like looking at an album, sir. It was not like a lecture we are listening, sitting bound to our chairs. We didn't know how the time went. It was very elaborate, sir. And one point was very good was the patient guilt factor, sir. None of the textbooks give this point, patient guilt factor. We are always oriented towards summing up all our knowledge and jumping with the conclusion, but rarely we come across this patient guilt factor and empathy for the patient. You have very nicely elaborated it, sir. And the role of interdepartmental follow-up in managing such tough cases, which as an endodontist, we say, yes, we have to do a root canal, but you have done the perio-ortho case. The last case was very, very interesting, sir. So on the whole, again, sir, none of 100 times we say thanks also, it's not. It's a very amazing and excellent. I think everybody would raise the hand for this, sir. I request all the participants who are viewing this webinar to kindly drop in questions in the question and answer session. We have received few questions. We are trying to answer through the chat box also, because we won't have sufficient time for everybody, for all the questions to be answered by all the panelists and the speakers, sir. So few questions we'll be taking with the panelists, and the other questions we'll be answering. Kindly check whether the questions are answered. Then the next one is, so we'll take the questions a little bit later. We'll just have the panelists also their words, sir. Then we can summarize all the questions at a time. With your permission, Shashi. Dr.
Sure,
Shashi,
sure.
sir. Yes, thanks, sir. As Albert Einstein quote goes, the only source of knowledge is experience. We have a panel of experts today to enrich us with their views also on this perplexed topic. I now request Dr. Sajeev Singh Yadav, sir, Head of the Department Conservative Dentistry and Endodontics, to share his opinions on this topic. Sir, may I request sir to share the screen, please? Sajeev, sir?
Yes, 1 minute.
Yes, sir, yes, sir.
Good evening, everybody, and very good morning to Shashi and all the other participants. Why Dyer said each day begins with a prayer of thank you, because thanking the better half, or thanking the God, or thanking your family for the beginning of the day is very important. The same way, 1 minute. We at the Department of Conservative Dentistry and Endodontics are privileged and honored to have a donation from Dr. Shashi Nalapati, who has donated an operating microscope. And his love and affection towards his alumni is shown on the way. This microscope was delivered on the day of Valentine's Day on 14th February, around 2 years back. And if you see in the corner, we have put a board thanking Dr. Shashi Nalapati for his kind contribution to the department. And I would say, Shashi, the lecture what you had given was very wonderful, and it was very thankful to all of us. And we have been enlightened by your lecture. I'll quickly go through the gist of the cracking the cracked tooth syndrome. Cracking the cracked tooth syndrome is actually a misnomer. Sometimes people refer them as green streak fracture, split tooth syndrome, and cracked tooth. And basically, we have to understand that it was the Endodontic Colleagues of Excellence in AE Supplement 2008. They have very clearly defined the various types of classified as craze lines, fractured cusp, cracked tooth, split tooth, and vertical root fractures. And how will you differentiate between these 5 factors, five classification given by AE? Basically, craze lines are present in all the tooth, especially in the adults. So don't mislead yourself by seeing a regular craze lines on the buccal surface of the anterior tooth or on the occlusal surface of the posterior tooth. Basically, craze lines are asymptomatic, pulp status is vital, and the prognosis is excellent. You can just keep it under observation, review it. Fractured cusps are usually there in patients where we have got symptoms of mild. The symptoms are mild and generally only on biting and on cold. The patient does not have any symptoms when he is biting on the when he is having a heat intake. Usually pulpal status is vital, prognosis is good. Then you have got a cracked tooth. You have got acute pain on biting, and this pain is usually there when the patient relieves his occlusion. Occasionally, there will be a sharp tooth to the cold. Pulpal state is variable. If the tooth has got reversible pulpitis, he will show signs of reversible pulpitis. But if it goes to irreversible pulpitis and it becomes very questionable, and actually, like Shashi has told, the prognosis is questionable and depends on the depth and the extent of the crack. And you got a split tooth. It's basically root canal treated tooth. There is a marked pain on chewing. This usually occurs in tooth where they have got plunger cusp or the cusp, and where the patient has got parafunctional habits. Prognosis poor unless crack terminates just subgingivally, or you can say, rather be specific, you can say if it is more than 5 to 6 millimeters subgingivally, the prognosis will be poor. Vertical root fractures, the vague pain, it mimics periodontal pain, and it is mainly root field tooth, root resection, and multi-rooted tooth. In the multi-rooted tooth is the only option, or I would rather say that any fractures or cracks which go subgingivally beyond 5 millimeters, you cannot expect a long-term good prognosis. Case history. Case history is very important in determining the type of fracture, because lack of knowledge regarding the case history, you have to examine the tooth in such a way that you always keep in the mind subjective and objective visual examination, and you have to do tactile examination of the suspected tooth also. The patient usually turn up and say that I'm suffering from vague pain. The pain is disappearing and appearing and disappearing, and the pain is not persistent. You have to do periapical testing where you can do percussion. Oblique percussions are mostly indications of a cracked tooth. Vitality testing is very important, but vitality testing is only one of the parts of the symptoms. And the cracked tooth syndrome is not a disease. It is one of the symptoms. You cannot manage a cracked tooth symptom unless you determine why the crack has occurred. One of the most important tests, which is available in every clinic, it is done by what is called a white tooth. You can use a slot, or you can also use a regular wooden stick, which you use for examinations, or you can also use the rubber cups, which are available on the LA bottles or any other bottles. Periodontal probing. Without any periodontal disease, if there is a periodontal probing, there is a chance that there is a crack which has gone subgingivally. Radiographic examination will only show, it will not show the cracks or crays. It will show a halo radiolucency in the radiographic examination is a presumptive of a cracked tooth. We can remove the restoration where the patient is symptomatic, remove the old restoration, put the stain and wash the stain and take a photograph at migration and look for staining which is persistent, or you can do transillumination. Transillumination, one of the important points in transillumination is you have to keep it on the buccal side under a dim room. You cannot use a halogen light of your dental chair, or you cannot use a direct light. You can have an indirect light which is behind the patient, but if you have transillumination to be done, you have to do it from the buccal side, and you have to absorb the basic principle to be remembered is transillumination. If the whole tooth is getting illuminated, that means the tooth does not have a crack. If the tooth is not getting illuminated wholly and it is stopping to a certain distance, that you can suspect a crack of the tooth. You can apply wedging forces and look for mobility. You can also do a surgical assessment by raising a flap and trying to look for the flap. Coming to the management, Abbott has given a flow chart, and he has taken this flow chart from American AE 2019, where he has divided into crazed lines, fracture scars, cracked tooth, split tooth, vertical root fracture. Crazed lines are basically present only on the enamel. A fractured cusp is present has got dentinal symptoms. It has got a cracked tooth has a pulpal symptoms. A cracked tooth also has the dentinal symptoms. A split tooth and a vertical root fractures are basically symptoms of periodontal origin. So going by one, like we said, Kray's lines, there are no symptoms, no treatment. You have to periodically keep it under review. But at the same time, Kray's lines Kray's line has to be identified that they are only the Kray's lines, they are not related to any deeper cracks. Coming to the dentinal symptoms of fractured cusp and cracked tooth, if it is reversible pulpitis, temporary restoration can be done and you can put a stainless steel band. If there is a cracked tooth with pulpal symptoms and it's got irreversible pulpitis, before starting the root canal treatment, because of the vibrations of the motor and the manipulation you do, it is always advisable to give a temporary restoration. I would prefer to give a stainless steel band. And if the cracked tooth without endodontic involved, remove the restoration and review the patient. In a case of dentinal symptoms, review the patients. If the symptoms continue, commence the root canal. If the symptoms is not there, if the symptom resolves by doing a temporary restoration or doing a bonded restoration, then you can keep it in the review and give a cuspal coverage. In the case of irreversible pulpitis, symptoms continue, commence the root canal, symptoms will resolve. After completion of the root canal, you have always remember that what was the cause of the fracture has to be eliminated. Cuspal coverage has to be done. And coming to the root involved tooth, there's a split tooth and a periodical root fracture. If the root is involved, there will be a periodontal cyst, there will be a pocket, there will be a sinus tract formation, there will be a halo radiolucency. Basically, these tooth have got very poor prognosis. I would not like to go detail into the case report. Just last week, we had a case in the department wherein there was a patient who has come to us with a symptoms of biting pain, and the symptoms were very vague. So we took a radiograph of the tooth, but the crack was not visible. But when we took the RVG of the same patient, and you could see that the crack, a mild crack, which was there on higher resolution, then we did a bite wing test and we did a trans-illumination test. The tooth got illuminated only on the half of the tooth. Then we suspected, and on doing a pulpal testing, we found that the tooth was going to the stage of irreversible pulpitis. Then we did a root canal. The root canal was finished yesterday. And there were other cases which were reported where I'm showing it just for the interest of what are the treatment modalities. There is a crack in 2-4. By using a bite wing wooden wedge, we could find out that the author could find out that there was a crack tooth. They did a trans-illumination in the third picture, and the trans-illumination stopped at the midline. Then the next step, the next step is to stainless steel band. The orthodontic band has to be given so as to prevent further wedging. And after doing that, after seeing it in the CBCT, the author could visualize that the crack on the dentin enamel and the dentin on the occlusal surface. He prepares a MOD cavity. Direct bonded MOD composite restoration was done. And remember, this is only an interim restoration. After that, the full cuspal coverage is given to this tooth. Another option is we have got all amalgam restorations. You can do air abrasion, remove the amalgam restoration. You can give a direct composite splint. After giving direct composite splint, it is kept in infra-occlusion. And on the direct composite splint, which is there, you can give a direct resin only is given to on the second molar, and you've got 3 years follow-up. And there is a provisional direct splint which is given, is gold adhesive only is given, which is kept out of the occlusion. After the provisional gold adhesive, you can give a indirect composite only onto the tooth, which will bring it back to the occlusion. This is a tooth with a fractured cusp in the mesiobuccal side, and it was going to the pulp. Root canal perforation, root canal treatment was done, and it was cuspally covered. So history, proper history, tooth assessment, specific diagnostic test. Specific diagnostic test is limited, not only limited to percussion, goes right up to the CBCT, but CBCT results are doubtful. Basically, you have to do all the diagnostic tests, take the history and come to a diagnosis. It can be either Kray's line, fractured cusp, it can be a cracked tooth, it can be a split tooth, and it can be a vertical root fracture. Thank you very much for the patient hearing. And once again, I would thank everybody for everything. Thank you, moderator, madam. If any questions are there, I would be glad to answer it.
Thank you, sir, for the valuable insight into the diagnosis and management of the cracked tooth syndrome. Dr. Murli Mohan sir has expressed he's typing the questions in the question answer session as there is a problem with the audio. So sir is not able to connect with the audio. So he told he will be answering. So I next invite the next panelist for the session, Dr. Jyoti Madam, Professor and Head, Department of Conservative Dentistry and Endodontics, Geetham Dental College, Visakhapatnam. I request Madam to share her opinions and views on this topic. Madam, may I welcome you now to share the screen?
Yeah. Are you able to see? Dr.
Yes,
Surya?
ma'am. Yes,
Are you
ma'am.
able
Yes, ma'am. You can proceed. Yes, ma'am. We are able to see the screen.
Yeah, Dr. Shashi has covered most of the theoretical and the clinical aspects related to the cracked tooth. And I just wanted to brush up some important points. Coming to the etiology part, the presence of deep class 1 cavities and MOD restorations, they predispose the tooth to a risk
Madam,
of
please
fracture.
switch on your
29
video,
times.
madam. Dr. Jyoti, sorry to interrupt you. Please switch on your video.
Yeah, okay. Video.
Yes, ma'am.
So the presence of deep class 1 cavities and MOD cavities predispose the tooth to a risk of fracture 29 times greater than the healthy teeth. And also, as sir already discussed about the occlusal stresses, that is most commonly cracked teeth are seen in the posterior area, that is the second molar teeth, because of the most occlusal stresses will be when the tooth is placed closer to the TMJ or the masticatory musculature, the forces will be exerted more on those teeth. So because of that, the mandibular second molars are the most prone for the cracked teeth. But as far as the vertical root fractures, normally most commonly seen in the roots of a tooth, which is having a mesodistally lesser dimension. That is most commonly we will be seeing the vertical root fractures in the maxillary second premolar teeth and in the curved roots of the mesiobuccal root of the maxillary first molar and the mesial root of the mandibular first molar, and then the mandibular premolars are more prone for the vertical root fractures. And particularly it was shown in the literature that the teeth that has taken as a support for that is as a pontic abutment teeth for the long span bridges, they are more prone for the vertical root fractures, premolars, that is particularly premolars. And the prevalence wise, I don't know what is the reason, but female to male ratio is 2:1 in actually in the female patients will be seeing the most of the vertical root fractures and the cracked teeth. And then coming to the diagnosis part, actually sir has told everything regarding that. And so visual examination is the most important thing. So here you can visually, first thing you have to check is the near the marginal ridges, because most of the cracks will start originating from the marginal ridges. So mesial and distal marginal ridges should be inspected properly under the proper light, and magnification is important thing. Here we can see the crack on the distal aspect of the second molar, and IOPA X-ray actually it is revealing the furcation involvement with the J-shaped radiolucency that indicates the root fracture at the somewhere in the lingual aspect, because radiograph will not be able to see it. After the extraction we are able to see the fracture line extending onto the root surface also. With the methylene blue staining, we can see the extent of the root fracture here. So bite test is one of the important tests for the diagnosing of the cracked teeth. And in a recent study by Yang et al., they reported that the tooth sleuth has a higher level of the sensitivity in detecting the cracked tooth than the cotton rolls and the wooden sticks. And for assessing whether there is a crack or not, sometimes it is necessary. We have to remove the old large extensive restorations, and after removal of the restorations, we are able to see the cracks, particularly extending towards the lingual side and towards the distal side here. And here actually the restoration is only very superficial, remaining dentin thickness is sufficient, but still after removing the restoration, we were able to see the crack line extending occlusally towards the distal side. Here mesiodistally it was extended. Like that, the radiographic examination, although essential, most of the times we will not be able to see the crack or the fracture line in the radiograph. Only when the fracture is extending buccolingual direction only we will be able to see in the radiographs. So here we are able to see the fracture line because it is extending buccolingually. And this is the case where the fracture has induced the internal resorption on the distal root of the mandibular first molar. So for that, we did the root canal treatment, and then the internal resorbed area was sealed with mineral trioxide aggregate, and the coronal coverage restoration was placed. So common findings of the VRF, that is the vertical root fracture. So normally we will be seeing the presence of sinus tract, and the deep periodontal probing depth will be seen, and radiologically we will be seeing the furcation involvement, that is the bone loss, and also the J-shaped or the halo-shaped radiolucency around the fractured root. Here also you can see the large halo-shaped radiolucency around this fractured premolar. Here also radiologically we will be able to see the radiolucency around the fractured root of the distal root. And role of CBCT. So whenever the other clinical signs and the symptoms are inconclusive of the final diagnosis, then definitely you are supposed to go for the CBCT for the proper diagnosis and the treatment planning. So here after taking the CBCT, we are able to see the fracture line extending from the lingual aspect towards the pulp. And the sagittal view, we are able to see the fracture line in a mesodistal direction just at the level of the pulp horn. So in a recent, that is in 2019, one study actually quoted that diode laser can be used as an adjunctive tool for early detection and the management of the symptomatic cracks with the improved long-term survival. And coming to the management of the protocol that is recommended by the National Center. So actually they were suggesting that the reversible pulpitis or the irreversible pulpitis, whenever you are suspecting a crack, you should essentially brace the tooth with the stainless steel band or the orthodontic band, so that you should minimize the cuspal deflection in that area. So, and also to prevent the exposure of the fracture site to the external intraoral environment. So for that, actually, initially you have to, whenever you are suspecting that, you have to give either the temporary crown, or you have to encircle the tooth with the cementation of the orthodontic band for that. And actually, according to Abbott, 3 months is the time indicated to assess the pulpal status of the reversible pulpitis caused by the cracked tooth. And if the endodontic treatment is not required within 6 months, then it is unlikely to be required in the later stages. That's what his research has told, that 3 months is the minimal time period that we have to check the vitality of the tooth. and removal of the old restorations, and we can see the crack in that area, and a direct composite restoration, that is after 3 years post-op clinical picture. And this is another case where the vertical, actually Dr. Shashi was telling heroic decisions we cannot take, but as academicians, we can do some of these cases if the patient is willing to go ahead with that. Even the prognosis is poor also. So here the vertical root fracture of the maxillary canine. So initially, before going for the intentional extraction of the tooth, we have done opened the access cavity and checked the fit of the FRC post and extracted the tooth. And these are the two segments and the preparation of the root was done with the 10% citric acid and 3% ferric chloride. And it was bonded, the fractured fragments were bonded with, I think, 4-meta containing bonding agent, and flowable composite was used to bond both the fragments, and then it was replanted and it was stabilized with the temporary splint for 2 weeks. And the picture here is the after 2 weeks of the removal of the splint. This is the 1 year follow-up picture. And here one more case of root amputation. So actually, initially we have done only the root canal treatment, and after 1 year after doing the root canal treatment, patient has come back with the chronic apical abscess. For doing the apical surgical procedure, we opened the flap and then we realized that there is a fracture of the mesiobuccal root. So we amputated that root, and this is the 1 year follow-up picture, radiograph. So this is the recent systematic review analysis published in 2019. They reported that about 95.2% of the teeth with coronal cracks survived at 5 years postoperatively, compared to 84% of the tooth survival rate for endodontically treated cracked teeth. So therefore, this high success rate indicates that the cracks can be treated predictably. Okay. I would like to thank Alumni Association organizing team for giving me this opportunity. Thank you all. This is now over to Dr. Surya.
Thank you, ma'am, for your valuable presentation. You have done an excellent sum up of all the cases along with the literary evidence, ma'am. We now, because most of the questions what we received from the participants have been answered, as already Shashi sir has told. Dr. Shashi, you have answered in your routine presentation most of the questions. We have just 1 or 2 questions which we need your special advice because of your expert follow-up of cases. Sir, can I take the question for you, sir? Dr. Shashi, sir?
Sure.
There's one thing like during orthodontic treatment, if the anchor tooth is diagnosed with, during the treatment, a cracked tooth syndrome. The treatment has started, in between the anchor tooth is detected with diagnosed with a cracked tooth syndrome. Is there any specific protocol? That means, are we waiting to be given no, before the forces are loaded again after treatment? Is there any such thing?
Very good question. Hard to say, because depends on the type of crack. If suppose you're talking about just a cuspal crack and that doesn't include anything into the dentin towards the pulp, then I don't think particularly there should be any change in the protocol for the orthodontic treatment. But let's say there are symptoms and the pulp is involved and it needs a root canal treatment, then I would say at least wait until the symptoms subside. It may take a week, 2 weeks to 4 weeks, maybe a couple of months before the tooth feels better. Nowadays, I don't see any bans on orthodontically treated teeth. They're always just a bracket and they're using.
Yes, sir. I mean,
so I would imagine, because with a cracked tooth, it's so important to place some sort of a coronal restoration on it. I would always tell the orthodontist to take off all the hardware off the tooth and place some sort of a definitive restoration, even if it is a band of some sort if they really don't want to crown the tooth. But I would prefer to have a crown on it. And I know with the improved bonding techniques now, even though orthodontists don't like to bond to porcelain crowns, you can place a bracket and do your orthodontic. So the only modification I would say is wait for the symptoms to reduce, have a crown placed on the tooth, and then carry on with your orthodontic treatment.
Thank you, sir. And in case 4, what you have showed, in case 4, there is a periapical lesion, only a periapical lesion was seen evident in that. And how was the diagnosis made of crack with only just...
I answered that question.
Yes.
It,
because somebody wanted it again, repetition, sir. That's the reason.
All the diagnostic testing was done. It's just that because I don't have time, I discussed maybe 50 cases in the 60 minutes. It's hard for me to present the entire diagnostic results. I did put out a few here and there, but of course, all diagnostic tests are done. Starting from everything that I outlined: history, obviously clinical exam, pulp testing, bite tests, and then radiographs, and then final. That's when you diagnose. But I just, for brevity and time's sake, you just kind of condense it to say, okay, this is cracked. I mean, I'm just telling you what the diagnosis is, and because I'm more talking about the treatment at that time. Yeah.
Yes, sir. So, and the last case which you have shown where the orthodontic extrusion was done with in the anterior tooth, the anterior last case,
right?
So, 9 years follow-up case. So in that splint, it acted as both as a splint and for extrusion, or just as an extrusion.
No, I don't know what Surekha is talking about when she says a splint. What the patient had was orthodontic treatment, wherein it was not a full arch. It was just two teeth lateral to the question tooth, and then they put brackets on them, and then they actually extruded the tooth. Once the tooth was extruded into its final position is when a lingual splint was placed to hold the tooth in its position. And of course, that splint was kept on until essentially the entire coronal treatment is done, meaning crowns, because there's so many temporary crowns he had while the tooth was being, once it was extruded and until, remember there's when a tooth is extruded, especially in the anterior, the root form is not ideal for a great restoration because the root is conical and the emergence profile of the root is so weird when it comes out. It's very hard to restore it properly. So because of that, you need a lot of temporization until you get a good gingival aesthetics, the soft tissue aesthetics around that tooth. So during that time,
Shashi, sorry to interrupt you. We are running out of time. We can't use the online platform for more than 10 more minutes. So thank you very much, Dr. Shashi, Dr. Jyoti, Dr. Sarjeev, Dr. Murli, Dr. Surya, Dr. Bhavana, and Dr. Pallavi for your contributions. Shashi, I have a surprise for you. Your batchmate, Surekha Sakala, has joined your webinar from Chicago. And also Dr. Usha, my batchmate, and 1966 batch senior alumni member, Dr. Anil Kumar Grover. I want all three of you, Anil sir, Usha, and Surekha, to say a few words. Please unmute yourselves and switch on your video. Anil sir, are you ready to speak? Surekha?
Yeah, I am ready.
Yeah, please go ahead.
Hey Shashi, hi Vivek, hi everyone who joined. It was a great presentation. And yeah, Shashi, like you were talking about, I was asking you about the lingual splint and the Jaden case, but thank you for clarifying that. The timing of this class was really good because the pandemic has put so much stress on everybody that everybody is coming up with cracked teeth because of increase in the parafunctional habits. So the timing wise, this topic was very good. And there is a saying in profession that if you have not seen enough failures, you have not practiced long enough. And Shashi is sharing both successes and failures with equal passion. And that's really great. I really enjoyed that. There were a few takeaways for me too. And yeah, I thoroughly enjoyed the presentation. As always, it's good to hear Shashi.
Thank you, Surekha. Usha, are you there?
Yes.
Speak up, Usha.
Hi, everybody. Hi, Shashi, Jyoti, and all the respected teachers, whoever are there, and other colleagues. Oh my God, what is this?
Yeah, please go on. Unmute yourself. You're muted. Yeah.
Okay. Can you see me?
Yeah, please go ahead.
Okay. Surekha, you just told what I wanted to say. So Shashi, see, this is what happens when the juniors are so aggressive than us. So thank you, everybody. I really liked your lecture, and we did have my first case when I went back to the practice was tooth cracks. The whole day I saw is patients coming with a cracked tooth, and this is a topic I wanted to hear also. So thank you for sharing
Thank you,
your
Usha.
to us. And
Thanks a lot, Usha,
thank you
for
again.
joining. Dr. Anil Kumar Grover, sir, from Delhi.
Am I audible?
Yes, sir. Please go ahead.
I think I can continue on the. I'm not able to get the screen as such.
We can hear you all right, sir. Please go ahead.
Sure. I think Vivek, this was a perfect presentation by Nalapathy. One. Two, I think I can recall having treated my earliest of those fractured tooth syndrome. That, in fact, it was initially termed as cracked tooth syndrome way back, and I started my practice in 71, 72. And I recall treating it just within 6 months of my practice. And very surprising that I had a perfect tooth, a perfect, just a simple amalgam restoration. And that's the time when I was not able to diagnose that I started looking into what exactly is cracked tooth syndrome. And coming to few observations which I wanted to suggest were that the moment the patient is in pain and reports with a cracked tooth, invariably that particular cusp involved will be the most hurting point when we check with a probe. So the best thing is to take a probe, straight probe, and part away along the inclines, and when the patient will feel pain, the first thing is to do is to take off that pressure point, one, and or if we find that the tooth is fractured on that cusp, it is ideal to remove the cusp and try to restore immediately, and then go ahead with the access and continue with the root canal treatment. I think all
Thank
this
you,
is
sir.
to be.
Thank you for
I
your.
think that's what I would say.
Thank you
And
for your.
one
and,
clinical tip which I realized was during these 50 years of endodontic practice, I'm plainly practicing endodontics only, though I'm a general dentist. So the first thing that I want to tell you was that the best thing to stop after the removal of the fragment is to take a combination of ferric chloride astringent along with alveogel, pack in that area and add a RM pack immediately as a first aid to the cracked tooth on the day 0. And then there's a time to discuss with the patient, the very valid point what Dr. Nalapathy said, discuss with your patient, options, everything. And then you have all the time on earth to decide that the tooth is going in for severe. Thank you very
thank
much,
you, sir.
everybody. It
Yeah,
was a
thanks a lot.
perfect and a beautiful presentation. And thanks for giving me a small opportunity to share with you.
Thank you, sir. Next time you
Thank
should
you.
organize
Sure.
your video and
Please,
internet
please.
speed. Yeah.
Yeah, sure.
Over to
Thank
Dr.
you.
Sri Krishna
Thank you, everybody.
for
Thank you.
vote of
Thank
thanks.
you very much. Please.
Thank you, sir.
Sure.
Thank you, Vivek sir. Can everybody hear me and see my?
Yeah.
Yes.
Yeah, please go ahead.
Go ahead.
Good evening, everyone. Let me begin by thanking the scientific committee for giving me an opportunity yet again to propose the vote of thanks for the second webinar of the Alumni Association of GDCH Hyderabad, which has broken the earlier record of the first webinar in terms of participation with 803 registrations. I wish to thank the President, Dr. G. Chandrasekhar, Secretary, Dr. N. Swami, Treasurer, Dr. D. Ramaraju, and all the Executive Committee members of the Alumni Association of GDCH Hyderabad for their constant support and valuable inputs in making this event a grand success. I also would like to thank the principal and faculty members of GDCH Hyderabad for their continuous support. It is indeed a blessing that we have amongst us several senior alumni members like Dr. N.S. Yadav, Dr. Anil Kumar Grover, Dr. Jay Kranti, Dr. Usha P, Dr. Sureka Sakla, and Dr. Shiv Kumar. Please pardon me if I have missed acknowledging other senior members individually, but I would like to express my heartfelt gratitude towards all of them individually for having taken time out to attend this event in spite of their busy schedules. I would like to a big thank you to our all the resource persons, particularly our speaker today, Dr. Shashidhar Nalapati. He has not been just magnanimous enough to just share his knowledge, but he is a person who has very magnanimously gifted an endo operating microscope to the Department of Conservative Dentistry, GDC Hyderabad. Thank you, sir, for your enlightening lecture. It is seldom that we get to see cases which have had a 20-year follow-up, that too huge number of cases. Thank you, sir. And I would like to thank our distinguished panelists for the day, Dr. Jyoti Mandava, Dr. Sanjeev Singh Yadav, and Dr. T. Murli Mohan for having shared their experience and who all are icons in the field of endodontics. I would like to thank Dr. VBP Suryakumari for playing a wonderful role as the moderator of this event with her excellent coordination skills and knowledge. Also, I would like to thank Dr. Y. Pallavi Reddy and Dr. B. Bhavana for answering the attendees' questions in the chat box. I would also like to thank the attendees, particularly for their enthusiastic participation in huge numbers. I think this is the first time that we could get as many as 505 participants, and we had to start streaming live on YouTube. This is the first time, and we will have more webinars where we will have a huge number of participations, and then our live streaming on YouTube would continue at the WOB networks. I would like to thank the Scientific Committee, Alumni Association of GDCH Hyderabad, headed by Dr. N. Vivek Vardhan Reddy, and its members in planning and organizing such an excellent and enriching webinar. Last but not the least, I would like to thank Mr. Gaganjit Singh and his team at WOW Alumni Networks for helping us conduct this event in a smooth and organized manner. I look forward to see you again in the upcoming webinar on a very interesting topic, which plays a very important role in day-to-day practice by Dr. D. Ramakant Reddy on the topic antimicrobial therapies, principles, pitfalls, and controversies on 7th February from 6 to 8 p.m., which happens to be a Sunday. We have pulled in some very distinguished panelists on board for that webinar, which include Dr. Colonel Jivan Kumar, Dr. Kishore Kumar, and Dr. N.V.S. Shekhar Reddy. And this event will be moderated by Dr. V. Vishalakshi. Once again, thank you, everyone. For now, we'll sign off. Good evening. I would like to hand over the proceedings to Dr. G. Chandrasekhar, President of Alumni Association, for the concluding remarks. Thank you, sir.
Once again, good evening. Before we close, I would like to share that we have crossed more than 500 participants, which is a record. Even in the international conventions also, we don't see so much of attendance. All credit will go to Dr. Vivek Vardhan Reddy, Principal, SVS Dental College, Mahbubnagar, and his team, and all the panelists for bringing so much of attendance. And Dr. Vivek has played a balancing act with all, and we are honored with his contribution at each and every program. And also the charisma of the speaker itself is spoken, and so much of it's of great value. That's the reason the number of participants were so high. I'm sure all of you have thoroughly enjoyed today's sessions, and The problem of cracked tooth is always a mystery. Many times in our routine practice, we face these problems and had a lot of headache, and it's a big question mark. And finally, the mystery is solved, and we must make a proper judgment whether to how to diagnose and how to save, or give a correct judgment to the patient and tell them whether it can be saved or it has to be extracted, or giving a try. Otherwise, you're going to put a big sorry face in front of the patient. Today's program is another success webinar for all of us, and we are going to continue to do the same in the future too, and they're going to be always useful and interesting. And thank Shashi, the speaker, and all the panelists and everyone working behind the scenes. And once again, thank one and all for the success of this webinar. Thank you, and we'll see you again after 2 weeks.
Thank you, sir. Thank you, Shashi, and thank you all the speakers.
Thank you,
Bye-bye.
guys.
See you after 2 weeks. Goodbye
Thank
to everyone. Bye.
Thank you. Thank you very much.